Good morning, everybody.
Thank you.
Rita,
good morning,
please.
everybody. First of all, I would like to thank all the organizers to give me the opportunity to be here, in particular Rosaria for the invitation, and Rita for the support, and of course, Phil for the kind introduction. So I am a biologist. I work in Hunt Foundation. Hunt is National Tumor Assistance Foundation, and it's one of the largest European organizations in the field of home supportive and palliative care. So our mission is to offer the possibility of spending the last period of life in familiar environments. So to this aim, we have multidisciplinary teams consisting of physicians and nurses and psychologists that assist patients and their caregivers at home during the different phases of the cancer disease. We are quite widespread in Italy because we are on 11 regions for a total of 29 cities. The service is free for the families and is offered in agreement with the national health system. So, in the last few years, Hunt assists about 6,000 new patients every year. In the last few years, we optimized and improved the electronic records. So we are able to collect the data of the patients on a cloud platform. This is our platform is Vitaever, and so we have a huge quantity of data about the patients, as you can imagine. So for the analysis we present today, we use a database including data exported from the clinical electronic records of 10,000 advanced cancer patients assisted during 2020 and 2021. For the analysis, we considered the patients assisted until death, so we have 7,150 patients. Our aim is to define some predictive model for assistance duration, care intensity, and pain therapy trend for to integrate into clinical practice to improve the organization of multidisciplinary team, facilitate the treatment planning, optimize resources, allocation. We have to take into account also the scarcity of healthcare professionals in Italy, and so to maximize the impact of care for patients and their family.
Hello. Let me just repeat that again. It's interesting. So what are they doing? This costs money. This costs time. This costs people. This costs resources that they don't have. Anything that they can do using the data and analytics to try to pull this into something sensible, to get some sort of better planning coverage, to be able to go out and get the right things for the people, can only be positive.
Yeah, okay. So we collected data at the admission of the patients. So we have demographics, obviously, diagnosis, and functional status. We use this parameter that is KPS that I explain later. The oncological therapy, pain therapy, and symptom intensity. We collected data during each home visit, so functional status, symptoms, and pain therapy. And we have the data regarding all the entire assistance, so assistance duration, number of physician home visits, and pain therapy trend. The starting database was exported from Vitaever, the cloud platform, to Excel. The analysis of this database was quite challenging for us because in this database, each row represents a home physician visit. So the main difficulty is that we have the number of visits was highly variable among patients, so as well as the frequencies of the visits, because the number and the interval between one visit and the next depends on the patient's needs and the clinical conditions. So this Excel sheet contains about 30 columns and 110,000 rows. So we realized that it was almost impossible to analyze this huge quantity of data with Excel and SPSS, that is the software I normally use. So we asked the help of Knime, the help of Alberto.
I can go? Okay, thanks, Rita.
Okay.
So you can imagine, guys, a database written by physician. I think is the most distant thing from a database, a physician writing numbers. But, okay, we use, as Rita said, only 2 years, 2020 and 21, and we censored the data, so we took only data of patient taken into account at a certain stage of the sickness up until to death, so the data were homogeneous, so to validate the data. The issue, as Rita anticipated, was to clean this database, because in certain cases we had 2 rows just to visit, in certain cases we had up to 20 visits to a patient. So we had to consolidate in some way. My knowledge of Python and Knime is not excellent. I studied this thing when I started when I was 61. Now I am 66. So, you know, I am a late student. I try to do my best. But I follow a rule, the Occam razor. The more simple, the best. So now you see a very strange and complicated flow. But what happened? For every parameter, I had to make a loop and decide in the group by node which characteristic we had to choose. For instance, we had to choose mean, median, mode, first, last, or I don't know, according to every parameter. Done in this way looks very complicated, but actually it's very easy to find error, because for every parameter you can go in his single row and you can find a mistake if you realize that there is a mistake. After that, we finally arrive to a clean data sheet where we could start analyzing. I'm sorry that is in Italian, but very quickly you can see the town, initial assistant, age, sex, diagnosis, KPS we will talk later, number of days of assistance, trend, this is derivate of a KPS, plus all the different parameters, sometimes numeric, sometimes qualitative. Then now I am ashamed, guys. I am really ashamed, because after Carsten, after Paolo, I also put a simple conda environment node, because I had to use a particular software, a Shikit survival. If you go and have a look at Shikit survival, you can make survival from a machine tool to a human being, according to the different parameters that you fit. Clearly, this was a node. Don't look, is double. From this node, what we need, we use the Cox regression. Do you want to say something about Cox regression? No. Okay. From this, we had some graph. We don't show you the graph, because we decided they were too technical. Our graph, they give the possibility of survival according to the number of days, according to the different characteristic of the patient. So diagnose, sex, north-south. We will see this component later. Later is explained. We had to select, and according to every bench of characteristic, we could create some curve that were interesting for us.
Yeah.
Rita, this is yours.
Yeah, we started with some descriptive explorative analysis. So this is an example of the mean and median assistance duration according the diagnosis. So the duration is highly variable among the diagnosis, and above all, we can note that the mean is always higher than the median. What does it mean? That the half the distribution of assistance duration is right skewed, so the half of our patients' lives survive less than 45 days, but the other half has a longer survival, even until here. So the question was if we may create some predictive model for the care duration and intensity. So we use all the data from most of the patients to create the model, and then we verified the quality of the model using 12 patients, considering only the data at admission. So you can explain better at this point.
Thanks.
Okay.
Let me just summarize one thing. Think about this. They've got lots of data throughout the time of a patient, but what's interesting is to know based on that very, very first
visit, from the first visit.
The very first visit. Can we learn something from all of this data about that very first visit? So as they continue, keep that in mind. You don't have all the data about a patient until death. That's not what's interesting. What's interesting is, what can we learn on the very first visit of a physician, and how does modeling help? Back over to you.
Thank you. So you will see here 12 patients. Of course, in this presentation, we had to cut a lot of slides, and you see only the top of the iceberg, because there were too many for the time, and some were very technical. We use very simple algorithm and workflow. Practically, we use example of Knime downloaded from Knime, because we didn't need an absolute precision. We will see. Okay. The first point, what Phil said, we receive patients and we have only 4 or 5 parameters. What can we do? We create 2 flows. In one flow, we have these 12 patients, first visit clean. In this one, we have a complete database. We use an auto-binner for the age, and these were the nodes that you saw before. These nodes are these. We selected sex, north-south, later we will see, diagnose, type of cancer, binned age, so group of age, and KPS, we will see later, that is the level of gravity of sickness. So practically, we selected from the big database, this one, a certain number of samples. We shuffled the sample in order to create some randomness, and we joined the data. Practically, we create some data for the new entrance patient using, for the data that we didn't have, some data from the existing sample, existing patient, of course, removed in order not to recreate an existing patient, but something that could be worked out by the algorithm. The algorithm looks ugly because I have to compress it a little, but it's an algorithm practically that you can, as I said, download from Knime, and is an XGBoost. We X-partitioner with a cross validation, we set up the parameter, and so on. What do we obtain? We integrate the data, as I said. We obtain two data, one initial data and one prediction. We use the prediction in our forecast. You will see the red one in both cases. This graph is the day of assistance. This graph is the number of visits of the doctor. The red one is what is the prediction, the result with the data that we mixed. The blue one is the prediction with the data, the prediction that the system make with the original, of course, the 4, 5, 6 parameter of the patient, the patient that is coming in. So in our prediction, in our sheet, 2, foresee the activity of doctor, of nurses, as I said, you see only the top of the iceberg, we will use these blue data that are not so different, of course, because are reshuffled because the type of sickness is similar and so on, but are more precise. Second, we made a model. In this case, we use an OTML for the pain therapy. Pain therapy, there are two pain therapies. We show you only one for simplicity because they are similar. One basic pain therapy and another on demand.
On demand, a rescue
demand.
for the breakthrough cancer pain. So
practically, if I can, practically exactly the same thing. This is the result that we have from the first database. And this is the prediction. In this case, this is the fixed pain therapy that we have for the single patient. We have the ID that represents one patient, and we can predict with a good, in this, the precision of the algorithm is about 65%. So 2/3 of probability, let's say. What Phil said at the beginning, I've been building cars for 30 years. A human being is very different in prediction. Rita, KPS.
Yes, we are also interested in scientific research in palliative care. That is a very specific field of research, and so we are also interested to study the disease trajectory of the different kind of cancer disease. So the parameter we use to perform this analysis is Karnofsky performance status. That is a standard way of measuring the ability of cancer patients to perform daily activities. So the higher scores are for patients that are able to carry out normal daily activity. The lower ones are for very sick, moribund, and then dead patients. So we analyze also the disease trajectory of our patients. So this is an example of the daily decrease of KPS for our patients. As you can see, the daily decrease, the speed of daily decrease is lower in the first stages of disease. So from KPS 80 to 70, from 70 to 60 is lower, and is much more higher in the last phases of disease.
Technically, is a derivative.
Yes.
Is a trajectory against time, no? Yep. Practically.
And we perform also analysis on the on the pain therapy according the functional status. So as you can see, the lower is the functional status, the more the patient needs strong opioids and painkiller. So
let me ask one question, because everybody will. I asked you, why were the yellow strong opiates so high?
Okay, this histogram is on frequencies or on percentage of patients. So the higher score represents a low number of patients that enter in assistance that has a high functional status. So, but they have pain. So they are assisted for the pain therapy, and we have a lot of high frequencies of strong opioids in the because
we could spend days talking about this diagram, but we have to move on, don't we? Really interesting.
Yeah.
There is one thing to say. We are Ant, as a consultant, a very famous professor for the University of Bologna, the boss of specialty of oncology school, and so on. He discovered one thing from the graph that he never noticed in all his career, that there is around 20% of patients who do not take any drug for pain. Normally we think cancer patients need pain. This discovery you can do only through numbers, through machine learning. That is one of the value of this type of research. Prego, Rita.
So the analyses are on progress. We have a lot of future perspective. We aim to refine this predictive model and to supply them with data of new patients, so to obtain a tool always updated, integrated into clinical practice. So and then we would like to deepen the study of disease trajectories to offer a more and more appropriate and timely care tailored on the multidimensional needs of the patients. The final aim is to improve the patient's outcomes, such as quality of life, quality of end of life, and possibly survival. This is the last slide. I analyzed the feedback message of the family assisted by our foundation by an LDA algorithm. So we send to the family a satisfaction questionnaire after the death of the patients. They have the possibility to write some sentences. I analyzed these messages, and these are more frequent words. So sorry because it is in Italian, but the most frequent words are angels, are heart, are assistance, are professionalism and openness and humanity and a lot of thanks. And so we encourage us to continue.
And personal, that's what I
mean.
There's lots of different words in here. I was going to translate this back into English, but I think most of you can get it. It works.
Yeah. So this is an example how technology can be applied to a very, very human dimension. So,
was that interesting?
Thank you for your attention.
Thank you.
We have time for a few questions, and I know we have people out there, and it's very hard to see. But let's get a couple of questions, and at the same time, if there's any questions from the virtual audience, that would be good. Questions. Always good to get a question or two. Yeah.
In case we are upstairs, we are here around, so
Yeah.
after.
I have a question for you, though. You have a lot of topics that you're going to work on next.
Yes.
Do you have one that's concrete? The next step?
The next step, technically, what we are doing. We are re-elaborating all the database because in 2022,
we optimized the collection of symptoms intensity. We used now a validated scale to collection. So the parameters are slightly different from 2020 and 2021. So we have to update all the system.
And this is from one point. The second point is to make interactive the flow.
Yeah.
Yep.
Practically, we have a new patient entering continuously, and with the visit of the doctor, we have to update the famous KPS and the famous parameter. So through the system that we saw yesterday, I think we will need some help from our friend of Knime because my capabilities are limited, I repeat.
You want a data app. Okay, we understand. We're going to help you with a data app.
Exactly, we will make a data app. So trying to automatize from the doctor, input of the doctor in the tablet, entering directly in the database and continuing to update the database. This, and then we have many other ideas, like nurses. You see the doctor, but for one visit of the doctor, there are 4 or 5 visits of nurses.
The visits of the doctors are almost one a week. Once a week. But we have nurses, we have psychologists, we have family service that bring to the patients the device, the drugs, and so this is the top of the iceberg. Yes, we analyze only the physician visit.
Then one more thing, in the database we are going to add socio-economic factor, because the life of this patient is highly dependent level of study, wellness of the family,
geographical area, because southern and northern is very different in Italy.
We have,
you have a lot to do.
Step by step, we are arriving.
What I love about this presentation is you're the expert, and old guys like us still have a lot to do with data, don't we?
Yeah.
This is so much fun. Thank you both very, very much.
Thank you.
Big round of applause.